Hi guys, welcome to another session. Today we're going to look at the drug Alfentanil. Alfentanil is commonly used in the ITU, it's used up in the ED, and it's also used intraoperatively for analgesic effects. We'll have a look at the presentation, we'll have a look at the mechanism of action, we'll have a look at the effects and the usage, and we'll have a little look at the pharmacokinetics of Alfentanil. When we're thinking about presentation, Alfentanil is a synthetic phenylpiperidine derivative. It's a potent, short-acting synthetic opioid agonist. It's a clear, colourless solution, and it comes in 1 mg per 2 ml ampules, but obviously there is variability depending on where you're working. As we said, it's used for a variety of things. Sedation on the ITU is probably one of the most potent reasons it's used. When we think about the mechanism of action of Alfentanil, it is an opioid, so it binds opioid receptors, and predominantly it has an affinity for the mu receptor, or as we're now calling it, the MOP receptor. These receptors are found throughout the central nervous system, with abundance in the cortex, the spinal cord, the peripheral nervous system as well. It's found within the respiratory tree, and it's also found within the GI tract. The mu receptor or MOP receptor is a GI protein-based receptor. So activation of that leads to a reduction in adenyl cyclase and then a reduction in cyclic AMP, and then downregulation of all those other modulators within the cell, and obviously has the effects of analgesia and other byproducts of opiate use. When we think about the actual usages of Alfentanil, it's great as a short-acting analgesic. It's great for taking the initial incision away of an abscess, for example. It's great for short-term procedural sedation in the ED, putting your shoulder back in or putting your finger back into place. And it's commonly used on the ITU for sedation of mechanically ventilated patients. It takes away respiratory drive, it provides tube tolerance, and it's normally sits alongside another primary sedation agent such as propofol. When we think about the effects of Alfentanil, some of these are positive and negatives depending on what you're using it for. You get CNS depression and you get analgesia and euphoria. Again, if it's for ventilation, that's probably a good thing. If it's not for ventilation, you're just trying to analgese, not necessarily a good thing. It can knock off your respiratory drive, it can give you nausea and vomiting, and it delays gastric emptying / gives you stasis as well. When we think about the pharmacokinetics of Alfentanil, it's a much shorter acting, faster acting agent than that of fentanyl. Alfentanil has got a pKa of 6.5, physiological pH of 7.4, so 89% of it is present in an unionized form and therefore able to cross lipid membranes when compared to fentanyl. It's got a smaller initial volume of distribution, and so despite smaller clearance, its elimination half-life is much shorter. It is metabolized almost exclusively in the liver, and it's metabolized down to noralfentanil, which is then excreted in the urine, with only about 1% of active metabolites excreted. The rest of it is inactive in nature. An important thing to note is that Alfentanil is metabolized by the same cytochrome enzymes as that of midazolam. So if you concurrently use midazolam and Alfentanil, the elimination half-lives of both are significantly increased, and that's something to be aware of if you end up concurrently using them on your ITU and you're trying to wake your patient up.